Welcome to CVS Live, our ongoing series that delivers timely perspectives and insights around leading healthcare issues happening now. I'm Angie Mioli, and I lead Aetna's Network Strategy and Provider Experience organization. Today, we'll talk about value-based care and accountable care organizations, their benefits such as increased innovation, better health outcomes, and reduced healthcare cost. The data from the Commonwealth Fund suggests that the U.S. healthcare system is the most expensive in the world, but Americans continue to live relatively unhealthier lives and shorter lives than peers in other high-income countries. The disparity between outcomes and costs has been driving an industry away from fee-for-service to value-based arrangements, and this evolution is changing how healthcare is paid for and coordinated. Value-based care aligns payments with value customers receive, and compared with the volume of patients a provider sees or the procedures delivered, so that providers and hospitals are rewarded for keeping patients and consumers healthier. Accountable care organizations, or ACOs, which are a network of doctors and hospitals that share financial and medical responsibility for providing coordinated care, can also help to limit unnecessary spending. Today's conversation aligns with our one-year anniversary of Aetna's announced collaboration with Cleveland Clinic in forming an ACO. During this discussion, we'll talk about how collaborations like the one between Cleveland Clinic and Aetna can lead to improved outcomes and a positive consumer experience. I'm excited to share that we have a great panel of experts here with me today. I'd like to introduce first Dr. Q Rhee, who is Senior Vice President, CVS Health, and our Chief Medical Officer at Aetna. Dr. Adam Myers, Chief of Population Health, Cleveland Clinic Community Care, and Wesley Wolf, who is Executive Director of Market and Network Services at the Cleveland Clinic. Welcome, gentlemen, and I'm looking forward to the conversation. So as we think about just understanding the basics, if you will, around value-based care and ACOs, Q, let's start with you. Can you share with our viewers how value-based care benefits both providers and their patients?
Yes, thank you, Angie, and thanks for having me on this panel. I reflect when I think about relationships between providers and patients and value-based arrangements as the basics of partnership and the role that we at Aetna and CVS Health have in facilitating the basics of what health and healthcare is ultimately about. It's those relationships and the value of partnership that we have with Cleveland Clinic, with providers, and the way we facilitate those important relationships to focus on quality and outcomes is the essence of what value-based care is about. I also would say that it is during this pandemic, there's an evolution of thinking about what values we have. And the values that we've had with Cleveland Clinic highlight our value of prevention as we think about this tough pandemic and the importance of vaccinations, primary prevention, secondary prevention, screening people for cancers, especially at a time when a lot of people are nervous about going back to care, but it's so important that they get those mammograms, those cervical cancer screens, and those colonoscopies. And of course, tertiary prevention, the treatment of these chronic illnesses, diabetes, heart disease, mental health issues. So the values that we have together in partnership around prevention and around whole health, thinking about the mind as well as the body, is really important. I'd also like to highlight, partly from my perspective of experience at IBM as their chief medical officer, the role of data. I'm so proud of the role that we have together in leveraging data analytics and artificial intelligence to advance what I would call the 5 V's of big data. Ultimately, there's an extraordinary variety of data that exists. There is a volume of data. There's a velocity of that data. And then there's the veracity of that data and the role that it plays in giving you value. And so together in these partnerships, we're advancing value through addressing these 5 V's And our own research has shown that when we have these value-based care arrangements, that we actually have more access to community resources and coordinators and team members, that we have more access to mental health. And so this is another very important component to highlight as it relates to our opportunities in these value-based care arrangements and how it aligns with our values.
Thanks, Q. So, a couple of things I picked up on, and then I want to ask Adam for his response as well. But, just hearing the importance of really truly building a partnership and a relationship, and then also how we're thinking about the delivery of care and really how we think about the outcomes. And you referenced thinking about the whole person, right? Thinking about the whole patient, which is inclusive of not just how many times or what we do, but how we really truly are building out a comprehensive and partnership model to be able to take care of consumers. So Adam, let me turn to you. At a very tactical level with Cleveland Clinic, when you think about care delivery and how care delivery differs under value-based arrangements, how do you compare that to fee-for-service?
Well, thanks, Angie. And I'll harken back to what you started off with by saying that the reality is that in the United States, out of the top 11 industrialized nations, we spend more on healthcare and have the worst outcomes. And that's just not a great trajectory. I like to describe it as we're not getting the juice for the squeeze. And we are not getting the value prop out of our spend and efforts that is necessary. Unfortunately, part of that, I believe, has to do with the funds flow within healthcare in the United States. Ideally, the funds flow wouldn't matter. Care would be care. The best things would be the best things to do, and that we would all be about producing the best outcomes at the most sustainable spend. But the reality is that how care is paid for and incentivized matters. And so that's where the transition from volume-based compensation and reimbursement to a value-based reimbursement really can become impactful on outcomes. What do I mean by that? In the fee-for-service world, care tends to be transactional, whereas in value-based, it's more relational. And so that's tactically a shift from patient presents with a specific episodic need. You provide or address that episodic need through diagnostic and treatment modalities. Fees are exchanged and you move on to the next episodic intervention. That's also a very reactive approach where you are passively healthcare system and healthcare providers and patients come to you for you to deliver this thing that they then passively receive called healthcare. And it's about shifting it from being reactive to accepting some responsibility for the outcomes of the panels of patients that you have agreed to care for. And so then you become proactive. So instead of just receiving patients, you're thinking, who are on my panels that we need to reach out proactively to close care gaps, to provide support that is necessary to promote their health. It turns it from a passive process for patients, that healthcare is something that they receive, to an active process that there's an expectation that they participate in help determining their home health outcomes. Sole providers turn into teams focused on the broad array of support for patients and the outcomes, including behavioral health social workers, pharmacists embedded in our practice, et cetera, to provide full spectrum care, like Caillou described, the whole health approach to care, because that's really what's impactful for people's outcomes. And then I think what you were really describing is the transition from treating disease to moving upstream in promotion of health. Those are the tactical changes that change as we enter into these sorts of arrangements that focus on a different way of looking at how care can be provided and how care is funded.
Yeah, Adam, I love the way you describe the passive application of patient care and what we need to move to. And I think that really resonates as well, because as we think about consumer disruption, I actually think that healthcare is probably one of the last industries or services, if you will, to be disrupted by the consumer. And it's here, right? So to your point, relative to where historically patients just received whatever they were given, if you will, from a relationship with a provider or an insurance carrier, they are disrupting that and saying, no, I need to have this way. I want to think about how I'm engaging in my healthcare, and I want to be able to have, solutions and services that are bringing this all together for me that, makes it simplified in a way. And so your point relative to how we're moving away from the just episode of you show up with an acute issue to really helping the healthcare system evolve to think about that patient as its whole. That not only I think is impactful financially in how we show up together as payer and provider, but it will be extremely impactful to consumers as well. So Aetna has been long dedicated, as well as Cleveland Clinic, to really facilitating access to high quality healthcare where, when, and how consumers need it. And last August, Cleveland Clinic announced the new collaboration with Aetna to form an ACO model that offers new plans and programs featuring Cleveland Clinic providers. At Aetna, we saw this as a great opportunity, one, because Cleveland Clinic is renowned for delivering exceptional patient care, and the partnership that we've had over the years as well. We knew that this collaboration would enable our members and Cleveland Clinic's patients to receive very personalized, very coordinated care. So Wes, I want to turn to you. I'm excited to have the opportunity to have you weigh in on, as you think about the partnership that Aetna and Cleveland Clinic have had over the years. How are you thinking about this collaboration and the ability to really take this to a new level in the community and in the marketplace?
That's a great question, Angie, and I appreciate the opportunity to be here today. I'll kind of go back to one of the things that Dr. Reese said earlier, and the ability to take data and use data, and how do we look at that and adjust what we're doing on a go-forward basis, informed by what we've done not only historically, but even very recently, adjusting in real time to what's happening on the ground. Aetna's been a fantastic partner from a data analytics perspective, not only analyzing the data, but feeding raw data over into our analytics platform so that we have both parties looking at data from slightly different but consistent perspectives so that we can come to real-time decisions that make the best sense for the partnership.
And if you think about, Wes, where we've come thus far and what we stood up, right? We were very prescriptive and specific in we wanted to together stand up a co-branded product. How is that going, and how are you thinking about the relationship to date?
So I think this was one of the first product launches that I've ever seen in the middle of a global pandemic, Angie. So I've got to be honest, that was a learning curve for most of us from that perspective, at least. But uptake probably wasn't what we had thought it would be when we started this process back in 2019. But I think the shopping behavior was suppressed due to the pandemic. Most small businesses were just trying to figure out how to keep their lights on. And I think that's a reasonable kind of reaction from the small business or mid-sized business community. But the Aetna team has been a fantastic partner as we've gone through this process. One of the reasons why we chose Aetna was the opportunity to partner and learn together. Cleveland Clinic is a learning organization. It's in our mission. It's who we are and who we've been for the last 100 years. And we were looking for a partner who had experience in this space, but who wasn't 100% proscriptive in how they approached this process. And so it's been iterative, it's been collaborative, and it's been an opportunity for both sides to learn and grow and adjust. And we're continuing to do that as we meet on a monthly basis. And how do we meet the market where the market is at that point in time, now that the world has changed fairly dramatically since we thought about what we were going to do starting these discussions back in 2018.
Thank you, Wes. I'm going to pull through a little bit more what you hit on, and that is, the ability to partner and learn. I think it's so important as in the healthcare space, as providers and payers are working together, that we give ourselves the latitude to be able to say some of this is new territory, and we do want it to be perfect, but we're going to have to adapt along the way. So I think that's key, to our viewers as they're thinking about the opportunities for partnerships. It really truly is valuable to spend the time as organizations, as Cleveland Clinic and Aetna did, to sit down and say, hey, where do we know we can show up together? And what can we each bring to the table? And how are we going to use that to really drive a mission to deliver top-notch, the best outcomes, the best experience for consumers when they enter into this product and ACO, so that we really can learn from it. And then we can say, hey, where's the next opportunity? So thank you for that. So going on to thinking about the evolving landscape and what's next, let's turn to the future and how things might evolve. During the pandemic, Wes, as you noticed, the industry saw delayed appointments, surgeries. Many providers were not able to maintain normal levels of patient volume just simply because they weren't ready for this. None of us were ready for it. And presenting for some, in some cases, cash flow challenges, just business challenges that they were not ready to deal with. Our businesses were not set up that way. I think about telemedicine all the time and the radical, quick pivot that we all did to engaging telemedicine in order to make the business, if you will, of healthcare still work. As I think about value-based care, however, value-based care models can provide better cash flow than a fee-for-service model. And I think attitudes with providers are shifting more strategic to, if I'm thinking about being able to now continue the quick evolution that I had to react to, if you will, in changing my business model during the pandemic, why don't I think about that in the long term? And how do I think about that in the long term? So many providers, I think, who haven't previously considered value-based arrangements like capitation models or pay for performance are really looking in the future to how would they adapt and how would they weather this new solution for them more holistically as a new business model. And so Q, I'd ask you, as the Chief Medical Officer for Aetna, how has the pandemic impacted some of these shared payment arrangements? And as we look ahead to new versions of value-based care, what do you think those will look like?
So the pandemic has changed all of us. It's challenged in many ways, I think, those relationships and the opportunities that we have to advance health. It's also created a literacy for everyone about what public health is. And so what I believe is so exciting is that these value-based arrangements, like with Cleveland Clinic, have had that trust so that in this moment of the pandemic, we can respond and serve the populations that we're looking to serve while they're challenged with this horrible infectious disease. But of course, their chronic illnesses and mental illnesses now are much more prominent. I like to talk about how we have a responsibility to flatten the COVID curve. Most people recognize that. They understand the concept of cases and hospitalizations and sadly deaths, and how we as a society have a responsibility to flatten the infectious disease curve of COVID. But I would suggest there are 3 other curves we've identified that were always there during this pandemic. And it's the curve of chronic illnesses, it's the curve of mental illnesses, and the curve of inequities. And so my view is value-based arrangements like with Cleveland Clinic are the basis for what I would call the future of values-based care, and recognizing not only the areas of prevention, primary, secondary, tertiary preventions, vaccinations, screenings, and chronic disease management, not only the concept of whole health, which includes mental and physical health, but now in this age of the pandemic and beyond, we recognize that the patient is evolving to a consumer. We recognize that patient, that consumer wants access. They want convenience. They want the ability to potentially go to one of our sites. 70% of Americans are within 3 miles of a CVS site. 85% of Americans are within 10 miles. And as we've discovered during this pandemic, with the tens of millions of people that we've vaccinated through our sites, people want that access, that convenience. They want that. You can't vaccinate people over the web. There are viruses, but not that type of, there's no vaccine. So this concept of having in person, but then of course, virtual. Once again, the pandemic has accelerated our concept of virtual care and huge opportunities here to meet people where they want to be, at home, on their hand, digital health, as well as the community health hub. And the last value I'm going to emphasize is what I know we're all committed to as a society. If you think about the challenges we have and the opportunities we have in health disparities to serve populations who are typically underserved, like in Cleveland, Ohio, like all across America, we've discovered this during this pandemic, that there is a significant percentage of the population that suffers from these inequities. And we have an extraordinary opportunity to address those inequities and deliver health equity and health justice.
Thanks, Q. So let's bring in Adam. So Adam, as you think about the evolution of population health, value-based, Cleveland Clinic has been deep into managing population health and really exploring new ways of addressing patient population, not just on a value-based level, but to some of Q's points relative to the evolution of what's been now called to a heightened alert from the pandemic. How do you think about that evolution and maybe continuing some of the good work that you all are already doing at Cleveland Clinic, and how you then fold that into value-based care arrangements?
Yeah, well, thank you for the question. As we started off earlier, how care is paid for is somewhat predictive of how it will be provided. And that was part of the reason why, even prior to the pandemic, we began a vigorous transition toward primary care capitation. Now, the reason for doing that wasn't so that we could garner more revenue or something along those lines. Certainly there were some outcomes to that end that revealed themselves during the pandemic, that to the extent that we've been in primary care capitation is the extent that our revenue stream remained flat in spite of the fact that volumes declined during that time. If you also think about it, revenue cycle management becomes very easy when you're in a capitated model. There's no claims to drop, there's no denials to manage, all of those different things become easier to do. But none of those things were the reason that we went into it. The reason we went into it is because we realized that virtual care, that team-based care, that care in people's homes, that remote monitoring were important care model design principles that we wanted to incorporate into how our teams operated, and that we didn't want to have to be thinking throughout that whole time, are these specific and discrete types of touches directly compensable? We wanted to accept an upfront revenue stream, care flexibly for our patients that have entrusted their care to us, and focus on a strong commitment to outcomes and get off that sort of fee-for-service treadmill, so to speak, and be able to function in truly operable, prospective-looking teams. And that's the reason we've done it, and it's proven great utility in that regard. So I think some of those trends will continue during COVID. I think it was a wake up for a lot of people from a revenue stream standpoint, and people are more interested in prospective payment models based on that. I think we're going to see much more care through care where people are, where they want it, when they want it, more care in their homes, and a real focus on outcomes and not just interventions. And then the final element that I'll see is, one of the things, again, is about activating people to be full participants in their own health outcomes. And that goes back to what Caillou said, engaging the hearts and the minds and the bodies in care, to do so with an effort toward health equity for people. and there's a lot of layers that go into that. But it's we've seen how it can work, and arrangements like this, payment arrangements like this, partnerships like this, really help facilitate those new care outcomes.
Thanks, Adam. I'm really excited about some of the points that you made, just relative to thinking about how the business is shifting. And the business is shifting, to your point, when you think about PCP capitation and the consistency of revenue stream and the ease, if you will, somewhat of administration, that then to me also says that allows us to take some waste out of the system that we had previously, take those dollars, attribute those dollars, right, and focus those dollars on the simplification and ease of convenience for our joint consumers as well. So, that's the things that excite me is, hey, it's we're getting kind of this double-edged opportunity here to say we can streamline consistency from a business standpoint and still manage what we need to do to make our to pay the bills, if you will. But there's an added layer of opportunity there, and that when we do that, we have opportunity then to reorient those processes or those people or those resources and dollars in another place and use them more wisely within the healthcare system. So that's really exciting to me. And we as well, payers, we want to be able to support the right financial models with the right support structure for providers. Because, if we go back to the early 90s, a lot of us were around doing capitation in the early 90s, and we know what happened. There was a lot of green bar paper that wasn't really very actionable. So, when we think about the way that we're structuring our different types of value-based arrangements at Aetna, we are really trying to ensure that we are providing different alternatives for providers based on where they might be even in their own value-based journey, and that we're also completing that with the right data, back to some accused points and back to your points, Adam, on you have to understand what's happening with the patient. So how do we make that more seamless? How do we ensure that we're showing up to support the provider to be very successful in these arrangements? I also think we'll start to see new collaboration and value-based arrangements in new areas that weren't necessarily traditional. And what I mean by that is, Adam, you pointed out primary care, right? Very traditional, even specialty bundles. But I'm talking and thinking about with the intense need for behavioral health services across the country, I think we'll start to see opportunities in the behavioral health space to think differently about value-based as well. So let's turn to Wes. So Wes, we talk a lot about this together, but it would be great for our viewers to hear from your perspective new ways that providers like Cleveland Clinic and payers like Aetna should be or could be working together beyond the typical value-based care or ACO arrangement.
Sure, Angie. And the one of the things that we've seen as we've gone through this process with the team at Aetna is not everyone has access to the same level of care in their local community that those here in Cleveland might have. So maybe you have members that are in more rural areas of the United States, and those members have to travel. You mentioned earlier about how COVID really changed the dynamic with respect to virtual care. We certainly saw this. Dr. Myers can speak from personal experience in what we saw here at Cleveland Clinic and the uptake of virtual care. But we have been really open to meeting patients where they are in that respect to say, look, if you need to meet with one of our specialists, as an example, let's hop on the phone. It may not be a compensable visit, right? I mean, maybe it's just an educational visit. Help us understand what you have going on, and then we'll help you get connected to the right place. We talk about this with the local team where you have medical directors who have a difficult case and don't know what to do with the patient. We've got physicians here at Cleveland Clinic who are willing to hop on the phone and talk to your medical directors and say, look, send us over the case file and we'll take a look at it. And maybe we know a physician in Cincinnati or Indianapolis or Atlanta who we think is really good at whatever that particular patient needs. Not everyone needs to come to Cleveland. It's one of the nice things about our particular salaried employed model is our physicians are focused on getting the patient what they need. And that doesn't always mean them traveling here. So getting the patient what they need, where they need it, right care, right time, right place, right? We've said that for a long time in this business. And it's really neat to be able to see that play out with members across the country.
Thanks, Wes. I agree with you. I think about the opportunity for reach, and you hit on the rural communities and communities that don't have access to care. And that kind of goes back to a lot of the points that were made here today, too, around the ability for us to think about touching and caring for populations that are struggling and where there are inequities in healthcare. And so, as I think about it, even as a consumer, as a mom, as a wife, as a daughter, I think it's critically important that we challenge ourselves to be able to leverage those opportunities with an institution like Cleveland Clinic that is investing in how do we really bring our care, our vision, our opportunities to others in other communities that might not have it, and how can we leverage those partnerships across this vast United States and back to hopefully one day getting ourselves in a much better resulting place on the list of the world of treating and really being able to have better outcomes for all Americans. So I'd like to thank my panelists today. I think it was a great conversation. I'm excited about the future of value-based care, but more importantly, I'm excited about the partnerships. I think that we have the ability to structure and really co-collaborate with across the United States as payers and providers. I'd like to thank you, Adam and Wes, for joining us today. Your insights, your collaboration, and your participation today are much appreciated. As we close out the session, you can view on the screen the access to where you can go to view further information about this broadcast today. And again, thank you and have a great day.